Thank you, Panel 3, for that engaging conversation. It's now time for our final panel of the day, Medical AI and Racial Bias, Ensuring Just Outcomes in Healthcare.
For our final panel, our moderator is Osagie Obaseki, and he's joined by four panelists, Joan Williams, Roxana Daneshjou, Tofunmi Omiye, and Jenna Lester.
Hi, welcome to the Berkeley Technology Law Journal Fall Symposium. My name is Osagie Obaseki. I'm a law professor at Berkeley Law with a joint appointment in the School of Public Health and Joint Medical Program. The title of this symposium is Regulating the Machine, Centering Racial Equity in Domestic and International Artificial Intelligence Policymaking. And this is panel 4, where we're going to focus on artificial intelligence and healthcare. So throughout this panel, we're going to explore a variety of questions, such as what are racial disparities in healthcare and how they extend to medical AI or medical artificial intelligence. We're going to talk about the ethical and regulatory challenges that come with integrating artificial intelligence into clinical practice. And we're going to examine efforts to develop just, reliable, and effective artificial intelligence systems for use in healthcare settings. Today, I am joined by four distinguished colleagues. First, Roxana Daneshjou, who's an assistant professor of biomedical data science and dermatology at Stanford School of Medicine. We also have Tofunmi Omiye, who's a postdoctoral scholar in dermatology at Stanford. We also have Jenna Lester, who is an associate professor and director of the Skin of Color program at UCSF. And we also have Joan Williams, who is a distinguished professor of law and founding director of the Equality Action Center at UC Law San Francisco. So many thanks to all of you for joining us today for this panel. And the first question is going to go to Jenna Lester. And I was wondering if you could briefly explain what are large language models and how has your work highlighted the challenges that might come from using large language models in a clinical setting?
Thank you so much for having me today. So large language models are something that I think more people across our society have become familiar with in recent years with the rise of the use of various large language models more commonly. But they're a type of artificial intelligence that uses deep learning to generate human-like text. And notice I said human-like because I think it's important to underscore the fact that large language models or AI in general is not sentient. It's not human. It doesn't feel. So it generates text that mimics humans and it's able to do that because of combing through tons of data available on the internet of all types. And so it can generate that text as a result. And the work that I've done with colleagues, including Dr. Daneshjou, including Roxana here, and Tofunmi, looks at how large language models might have applications in the clinical setting. And I'll say it's something that I have a lot of concerns about, despite the fact that it is largely rolling out in many clinical environments. But one of the papers that we worked on looked at using ChatGPT as a way to maybe not make clinical decisions, but inquired ChatGPT as though we were asking clinical questions. So, for example, something that we do in medicine is look at kidney function. So kidney function is an important biological marker for a lot of different things. It can determine dosages of medications. It can determine if someone's recovering from a particular illness in the way that they should. It can determine how sick someone might be if they have chronic renal disease or chronic kidney disease. And if that number isn't at the right level, they may not be listed for a kidney transplant if they're in fact sick enough. And over the years, it's a racist sort of relic of medicine past was the fact that Black people's kidney function is better than white people's kidney function. And so the numbers were adjusted. There was a correction factor to account for the fact that Black people had different kidney function than white people. And that has been implicated in the fact that Black people's kidney function has to fall to a much worse level before they're listed for a renal transplant, and has been implicated in disparities in receiving renal transplants. So that information is out there on the internet. And despite the fact that I believe it was in 2020 that it was officially adopted that that correction factor should no longer be used, or maybe it was 2021, I can't remember the exact year, but it is widely accepted that that correction factor should no longer be used because of the things I just mentioned. But ChatGPT doesn't necessarily know that, because it is trained on the body of information on the internet. So in one of the papers that we published, we asked ChatGPT, how do you calculate kidney function in a Black woman? And we asked a number of other questions too, because similar racist tropes exist with calculating lung function and whether Black people actually experience pain and to what level, et cetera. So ChatGPT responded with the correction factor, which is the historical racist way of calculating kidney function. And not only did it do that, but when we asked it to clarify, it doubled down on its racist ideas, saying Black people have more muscle mass than white people do. And race is a social construct. So there is no way that we can take a social construct and superimpose it on and create some sort of biological or genetic assumptions. So this is just one of many ways that that I think it is problematic to translate these large language models to the clinical setting.
Mm-hmm. Great. So that's really interesting. And part of what I hear you saying, Jen, is that large language models are really good at looking at the past. But they look at the past without any type of context. So, for example, as you were saying, ChatGPT doesn't quite understand that the facts that are kind of seen as kind of informing how the model understands social reality were produced by a past histories of racism and other forms of discrimination that bring those past disparities back into the present as if these are simply the way things are naturally, rather than a product of the types of societies that we've lived in, both past and present. So that is to say that large language models, while useful, aren't very discriminating, and I'm being that sense of not being able to tease out how these types of past inequalities can shape their realities in ways that could be quite inaccurate and not take into account the ways that humans have treated other humans quite poorly.
Exactly. And I think in the hands of someone who doesn't know, it becomes even more dangerous. So the way that the text is generated sounds very authoritative, and like that
Right.
It's really putting its nickel down on something. And if you don't know, then you're, I think, susceptible to believing something that may not be correct.
Right. And I think that's a really good point too, because it's re-articulating past biases through what seems like a futuristic, authoritative voice that then kind of brings all these kind of conversations we've had in the past about kind of correcting these kind of biases and making sure we have some clarity. It just kind of brings it all to the forefront again, as if it's a neutral articulation of natural differences between people. Roxana, you've done some work in this area. I wanted to give you an opportunity to jump in as well on this question.
Yeah, so I think an important and everything, Jenna says absolutely, key here. And I just want to expand upon how large language models are produced. So first of all, I like to call it a sausage because nobody really knows how the sausage is made. These companies don't share what data is used to build these models, how they're tested, all of this stuff. So it's a sausage and we don't know quite what's in it. But I guess people are eating it anyway. But we know some basic fundamentals about how models are created. And so I think understanding that is very key to understanding why all of the problems Jenna mentioned happen. So the first stage of training these models is something called self-supervised learning. The model is looking at a large amount of text. It could be the whole internet. It could be copyrighted material. Like I said, we don't know because they don't tell us, but assume that it's like everything on the internet, textbooks, all of that. And what they do is the model plays a game with itself, essentially. None of that data is labeled for what's accurate, inaccurate, what's true, what's not, what's racist, what's not. It's just all taken in And the model plays a game where it tries to predict the next word in a sentence. So, for example, if I were to say the sentence, the dog ran across the grass and chased after the blank, some people might think ball, some people might think squirrel or cat. Why do you think that? Because you've lived in the world and picked up on how some of these words are associated. And that's what these models are trying to learn, is how words are associated with one another. Think of it as fancy autocomplete. This is particularly problematic because, and I'm going to mispronounce the name, Verhagen et al. In 2011 published a paper in the British Journal of Psychology looking how words are associated in newspapers, books, etc. by race. And he found that this structural racism goes throughout. So words that are associated with Black race in written text include things like poor, violent, lazy, while words commonly associated with white race include wealthy, progressive, conventional. So they went through and they analyzed large amounts of text and looked at how words are associated with one another. And now you have these language models that are training on text and picking up these dangerous, harmful associations that are untrue and basically being trained and learning the systemic racism that exists. After the model is trained in that way, the next thing that happens is reinforcement learning with human feedback. And what happens there, and if you've used ChatGPT, you might see this where it gives you either slightly different responses and asks you to rate it, or it asks you to give a thumbs up or a thumbs down. Basically, humans giving feedback to models. This is sort of the level at which you can maybe begin to try to get rid of harmful behaviors in models. However, unfortunately, as Jenna mentioned, a lot of that still exists in the models and comes from the fact that a lot of these biases and racist tropes just exist in, medical literature, general literature, and that's what these models are learning from.
Right. That's super helpful. And one of the things when I am teaching, when I teach medical students or I teach about my class on bioethics, one thing I always try to emphasize to my students is that, medicine has this really long history and legacy of using terrible language to talk about people. And oftentimes it gets kind of baked into the clinical model in terms of how we characterize certain populations. And so if that's something that we're still struggling with in 2025, you can imagine the large databases that are being culled by large language models to kind of come up with ways of constructing answers to various questions. And these models aren't always able to disentangle, what might be a factual clinical answer from the very kind of could be very troublesome ways in which we talk about people in the past. So as you're saying, Roxana, the ways in which we talk about people and the words that we use is shaping the way that these models are learning and the answers that are giving people, and that has an impact. So we're starting down this path of kind of talking about what has led large language models to perform, in this very biased way. And so, Tofunmi, I want you to give you an opportunity to kind of jump into this conversation, ask you about, not only why this is happening, but also talk about what are some of the most significant effects of large language model bias on health outcomes.
Yeah, thank you for the question. I'll preface by saying that everything Jenna and Roxana mentioned, we can kind of that's just a nice segue to think about why this is happening. It's just because all the data out there is really, biased, right? And then you have all these models that are trained on that data. And like Roxana was mentioning, you have companies that at least do not care enough, to take that extra step in evaluating if these models are biased or not, right? So you kind of have all those pitfalls, at multiple instances. Then, of course, what comes out is a model that is biased, across race and gender. But again, what we're talking about, it matters because so many studies have shown, just the effects of, bias models or, healthcare delivery being biased, affecting, people of color or just other populations here in the US and other regions of the world. Just like Jenna mentioned, right? Like we talk about the kidney function equation, which because people have been using that's just this, I kind of see like a large language model is like a mathematical model, right? It starts from equations and you kind of build it up to this very complex model. And we're using those equations in the past, and then we found out that like Black people were not getting kidney transplants as they should, right? And we have more recent data that's shown like there's this paper by Zaid Omiye actually at Berkeley showing that some of the machine learning models that were deployed in some of the VA hospitals, right? They were causing like different like recommendations for Black people, and that was just leading to worse outcome for them. And just because like healthcare can lead to mortality and morbidity, and everyone that's had to deal with the healthcare system understands this. So when you bring out those new models that are being implemented in all those settings without those stop gaps or without the rigorous evaluation that is needed, what you just see is, you just continue to amplify the already worse outcomes of these, Black minority populations. And I think those are the most important effects, like either just increased death rates, increase, morbidity, and all the other, downstream effects, increased costs. Also, not just even for these populations, but it ends up being increased costs for the system because, they have to come back and spend more and more money in the healthcare system. And we think that LLMs are going to solve this problem, but they can just even worsen it and increase, cost and just worsen outcome for especially for minority populations.
And so as we think about solutions to this problem, Jenna, are there ways to mitigate this type of bias in the development of AI models? Are there things that we can do to kind of try to contain this problem?
Yeah, well, I think there are some specific things that that people have looked at, and specifically in dermatology, and I'll let Roxana talk about that. But one thing I want to say is it may feel obvious after hearing what we talked about with training data to say, well, we just need to make the data that the models are trained on, we just need to make that equal in some way. In dermatology, we need to have equal representation in photographs if we're training a model to try to diagnose skin disease. And that's not, I don't think that's enough. And this is something that was highlighted in Algorithmic Reparations by April Williams and co-authors. The fact that it's not just enough to balance the data and make sure representation is equal when data is flowing through a society that is already unequal. So the data that we use is tainted by the world that we live in. And an example of this is in dermatology. We took a paper that I did several years ago, looked at just counting photos of patients, of people represented in our common teaching texts and what skin tone was represented. And we found that only about a third of photos, thousands of photos across multiple texts and different electronic resources were in patients with dark skin. And so when you're learning, that presents a problem. When a model is training, that presents a problem. But even more so, what we found was even though only about a third of the total photos were in dark skin tones, over 50% of the photos representing sexually transmitted infections were in dark skin tones. So that to me is an example of how we take pictures and capture people in scenarios that reinforce the beliefs we already have of them. Or maybe it is that many of the photos of people with dark skin come from a certain clinical setting where clinicians feel more entitled to taking photographs of people in more sort of compromising scenarios, but they're unwilling to do the same thing of people with light skin. So there's lots of different ways you might perceive that, and if we were to just balance out the photos and the body of photographs out there have an unequal representation of certain skin diseases, then again, we are just reinforcing and programming into the model something that already exists that represents how our society is unequal.
Right.
So, yeah.
Yeah. So I think that's a really important point. What you're kind of inviting us to think about is this kind of issue of how data is not simply an objective collection of facts, but rather it's a function or a product of the social and political moment in which that data was kind of collected. If you think about data in that way, then using large language models can be an incredibly problematic way to seek answers about truth in the world. because it's always kind of revisiting this past that was constituted by all types of biased ways of stratifying the world.
Exactly. I think that's spot on. Um again, like it's not just about balancing things, because I'm not sure that we can achieve that in within a AI based, an artificial intelligence based tool, when we haven't achieved that and worked on that as human beings.
Right. And then this kind of reparative lens that you're inviting us to think about is one that both acknowledges this past, but also encourages us to say, look, if AI is going to become the voice of the future, then it simply can't rely upon past tropes. It has to, in a sense, acknowledge that past and modify the voice so that it can produce the forms of inclusion and equality that we want to see. So that is to say that AI has to do a little bit more than simply kind of look at the past as a way to predict the future. It has to do more to kind of align with the values for creating the type of world that we want to live in.
Yep.
Roxana, do you want to join us in this conversation as well?
Absolutely. I would just love everything that you said. I was thinking I need to get a quote. I need to get some of this in quotes so I can put it in my PowerPoint. But I just want to sort of double click on what Jenna said about inequity in the world, because at the end of the day, these AI systems are not autonomous, and we're not anywhere near autonomous systems anyway. So we're talking about human AI systems and testing human AI systems. And one thing that we found in dermatology, at least, is that when you ask physicians to look at images of skin disease, like the same kind of diseases in Black versus white skin, we did a systematic study of this. They actually did far worse on Black skin. This is not surprising, unfortunately, because of exactly kind of harking back to the study that Jenna did, looking at photography in our academic journals, our textbooks. There's not, the things that we learn from don't have appropriate representation. And that gets encoded in the human beings, the physicians. We found that if you give physicians, primary care doctors, and dermatologists a fair AI model that has, same accuracy across all, the skin tones, they actually incorporate the advice from the AI models differently based on the skin tone in some cases. And this is why I think it just goes back to what was mentioned, which is like, oh yeah, creating a fair AI system isn't the end all be all, because at the end of the day, you have humans incorporating, that information. And that cause, that's the fundamental issue. So what I always say in terms of like how people always ask, like, how do you test these models? I say you have to test and monitor and assess how the model does in the real world clinical setting, and how unintentional sort of biases come through, either from the human side or the AI side, or from the compound system of them working together. And again, and like sometimes you don't anticipate, or the creators of these models don't anticipate, because unfortunately, tech is not a very diverse field, how some of these problems might arise. The best example of this is the work by Dr. Ziad Obermeyer that was published in Science, that found that an algorithm that had been implemented widely throughout hospitals to help predict who needed additional medical support and care after hospital discharge disproportionately gave resources to white patients over Black patients. And the reason that happened is because they used healthcare spending as a proxy for medical need. And what happens is, because of the, systemic inequalities in access to care in our society, Black patients that were much, much sicker than white patients had less healthcare spending. And so that was the algorithm was thinking, oh, they're less sick. So that's another thing I want to mention is just we have to be so careful because these algorithms, people might think they've designed something that is fair. They might think it, but if we don't audit it before it actually gets implemented, it can have a devastating impact of increasing inequities where inequities already exist.
Right. Thank you. Thank you. And so we're so fortunate for this to be an interdisciplinary panel. So we have Joan Williams with us, who is not a clinician, but has done incredible work in the field of work law throughout her incredible career. And Joan, you've kind of done a lot of work looking at how AI tools have been widely used in hiring and other kind of talent management, human resource functions. I was wondering if you could help talk about what are some of the risks with that. And I think, your experience in work law will help inform and deepen and enrich this conversation about how AI is used in healthcare.
Well, I can't pretend to be an expert on AI, but I do know a lot about the workplace. And in fact, we currently have a large NSF grant to study a large healthcare organization. So I have very current information about the kinds of biases that play out in the healthcare workplace. And the biases that we found in this particular organization are larger than any we have ever found in any industry, which was some of them are as large as 50 percentage points. These are huge differentials. Another thing that we found is the way we typically measure bias is we have a 10-minute climate survey that asks things like, I have to prove myself more than my colleagues with similar education and experience. And we compare the experience of the different groups. And one thing that is nigh invariable is that the experience, depending on the which of the patterns of bias, and I'll talk about them in a minute, you're looking at. For example, the first pattern, which we call prove it again, some groups have to prove themselves more than others. And it's almost invariable that white men report the least of this, and that women of color report the most, and among women of color, Black women report the mostest. In this particular in healthcare environment, though, it was really interesting. Of course, it's not a Black-white environment. There are a number of Asians. And we found that South Asian women reported more even than Black and Latina women, which was truly astonishing. And one of the things that we're finding is that there's really a very sharp divergence in experience between South Asian women and South Asian men. South Asian men actually often don't experience the kind of questions about their leadership ability that all other Asians do. So there's there are a lot of distinct patterns in the healthcare workplace. And the level of bias, unfortunately, is kind of breathtaking. The other thing to recognize is that this has a direct effect on health outcomes, because as people know, doctors who are people of color tend to have better outcomes with patients who are people of color, and women doctors tend to have better outcomes across the board with their patients. And yet we have healthcare workplaces that are systematically selecting for a specific group. And so, going back to what Jenna said, what's the training set? There are two different choices for training set. One is external. That's the training set type that Jenna was talking about, where you just go out and scrape the net. And when you scrape the net, you're going to find racial bias. And of course, these systems are trying to correct for it. And so some of them, for example, are trained not to take note of whether it's a man or a woman or a person of color or a white person. But if you think about that in a very concrete hiring context, if you're washing out all that information, first of all, it's not that easy. I mean, you can, there's one of the famous studies called I call it the Greg Jamal study, where Jamal needed 8 years of experience compared to Greg in order to get the equal number of callbacks. So you can correct for Greg Jamal, but do you correct for someone who says that one of their major activities was in the Asian Pacific Bar Association or the women's a club of some? And if you first of all, a lot of places might not think so. It's not that easy to eliminate race and gender information. And if you really do it rigorously, you would have quite bland resumes from women and people of color because a lot of their activities would not be reported. So it is not that easy to correct for bias in an external data set. And of course, some of these AI systems now are learning based on internal data sets. So for example, here is the profile of the person who's aced it at our organization. We want more like this person. Well, we've done actually experiments. We have a particular approach to eliminating bias. It's called bias interrupters, and it's no news to scientists. You drive people to the evidence, a consistent criteria based on evidence, and you tell them what bias looks like. That's what bias interrupters are. And we've done experiments inside 20 companies, documenting what forms of bias they had and whether bias interrupters helped. Spoiler alert, bias interrupters did help in under 6 months, in some cases eliminating very dramatic kinds of bias. But one of the things we found in one of these companies, which after all, was a company that had chosen to work with us, so they were very attuned to these issues, is that they were hiring, once they looked at their data, they were hiring white men with lower ratings than any other group. And to be bumped out of the pool as a white man, you kind of had to have ratings really in the toilet. And so women and people of color with much, much higher ratings were not being hired. And there's your internal data set. If you haven't analyzed your internal data for patterns of racial and gender bias and bias based on things like social class origin, which are important in some industries, not other. Race and gender, they're always important. But if you haven't analyzed your training set for those patterns, you're just going to replicate them.
Wow, that's really interesting. One thing you started to mention or talk about were the basic patterns of workplace bias. And you mentioned a few of them. I wanted to give you an opportunity to round that out a little bit and also ask how can AI, how it might inadvertently reflect these biases?
Well, there are 5. I've mentioned the first, prove it again bias. Prove it again bias just means that some groups, and in medicine, there's actually really cool studies where they ask people to imagine a scientist or imagine a doctor. And most kids, they draw a kind of tall white guy. And so all other groups kind of have to give a little bit more evidence that they're actually a good fit. And that's one of the reasons. So if you have an AI system that is based on hiring or any other talent management process that looks for people with potential, there's really robust, really old, this is old news research. It's been established for decades that white men are seen as having more potential, and other groups actually have to show cash on the barrel. So that's prove it again, and that's one of the ways that AI systems are going to scrape it off the web. Another thing, again, this has been well documented by hundreds, if not thousands, of studies since at least the 1990s. That we call it the tightrope. Authoritativeness and ambition are commonly seen as evidence of leadership, but they're much more readily accepted in white men than any other group. So if Black men behave in authoritative ways, we actually see we have like 20,000 N on this. They're often called intimidating. Latinas in tech are often called feisty. And if you think about what feisty means, it means you're behaving in an authoritative fashion, and I'm interpreting it as cute. And what this is a very common form of pattern of bias in performance evaluations. We've coded like over 100,000 performance evaluations. One of the strongest patterns of bias in performance evaluations is that people of color and women are much more likely to be faulted for personality problems than white men are. And just have their personalities mentioned. And men of color in particular are particularly likely, lots more likely than other groups to be faulted for negative personality traits. Again, we have eliminated these kinds of biases in under 6 months. So they can be eliminated by very simple bias interrupters, but they typically aren't. So the tightrope is a very, very influential in hiring, in performance evaluations, in a lot of other HR processes that are now being consigned to AI. A quick example for the strongest form of gender bias is bias against mothers, the maternal wall. And there was I believe, a recent study that showed that an AI system had been told to ding people who had a gap in their resume. Well, guess who has a gap in their resume more than other people? Mothers. And then there are also, as we've mentioned, distinct racial stereotypes. Asians are good at technical things, but not at leadership, is a common stereotype of Asian Americans. So those, if you're looking for leadership, and you just read the web, you're going to read that Asians, especially East Asians and South Asian women, to get technical, aren't very good at leadership. And you're not going to be choosing those candidates unless you somehow go back after the training set and in a very expensive and complicated way, try to correct for these biases.
Thank you, Joan. So this is, I think the conversation is evolving in a really interesting way because we're seeing these synergies in how AI can amplify kind of biases that are intrinsic to how institutions kind of manage themselves. And so if we take that as a common theme, I think a next part of this conversation could look at, what frameworks might help us manage these issues. So are there ways to mitigate these biases are there ways to mitigate these biases during the development of AI models? So they say it's training the models themselves. I think earlier one panelist said that it's not just about getting better data, that there has to be other commitments. But are there types of technical ways to engage the technologies themselves that can put us in a better position to have better outcomes, whether it's in the workplace or in the clinic?
So something I think about is beyond training. Training is one step, even though we know it cannot directly eliminate it. I still think there's lots of effort to do from the training perspective in the aspect of data gathering. The other aspect of training, like Roxana was mentioning when she was talking about development of LLMs, is things like, self-supervised learning, fine-tuning, and some of those things, they're usually like we call them loss functions, which is what you optimize the model for. So these are usually like mathematical functions in which the goal is to make the model, perform the best possible, like in regards to those loss functions. And that could be in different forms. I think one thing that some people have talked about is like demographic parity or calibration fairness. So when you train the models, like try to do subgroup analyses, right? Like optimize them first based on from the perspective of the loss function and see how they perform across different groups. And then you can also like engineer like unique loss functions that tries to penalize them for being, biased against these different groups. But beyond that aspect of, like training from a methodological perspective, another thing is like, evaluation. So when you're deploying these models. Like the other thing is also, again, evaluating what they look like across different subgroups and making sure that like there's no like significant disparity in outcomes across the different subgroups. But even after all of that is done, you've done the evaluation and even the post-training evaluation, and then you deploy in a clinical setting, like Roxana had alluded to. So something is kind of like this recurrent real world, monitoring. I kind of think about it, when you look at pharma trials and you do phase one, phase two, phase three, and even when the pharmaceutical product is in the real world, you still have this monitoring and reporting method. And I think something, quarterly, surveys, like Joanna's mentioned, through some surveys that they use, kind of like using all these other methods to see how the AI models perform, and just, again, evaluating with either the companies that built them, and continue to track all those different subgroups within the clinical setting and see if there's, again, any significant disparity. I think like attacking this deployment or even development of large algorithm models in all those multiple forms is probably at least one of the best ways to mitigate the risk. And you can even catch it early on, right? Kind of like the Zaid Obermeyer's paper, where imagine that's been done very early on. People would have been able to discover some of the worst outcomes that it was causing for Black populations. So just to recap, is thinking about, still data set training, still trying to do something in that aspect. The methodological aspect of loss functions and penalizing the models across different subgroups, and also evaluating like across different demographics, and also like doing this post-deployment, recurrent monitoring like you do in a pharmaceutical clinical trial.
Great, thank you.
Right.
And so, some commentators have talked about how, this idea that, there's no way we're ever going to eliminate bias entirely from artificial intelligence or from large language models, but we have to become comfortable with some level of risk, or this idea of acceptable risk. And so, Jenna, what do you think about this idea of acceptable risk in large language models? Should there be some threshold that we should find to be okay, or should we hold ourselves to some type of higher standard when it comes to the use of these technologies?
I mean, I think, to put it bluntly, like, how many people are you okay with killing? How many people are you okay with dying? How many people are you okay with being harmed? Um, and I think the question really shouldn't be directed to the people who are developing the model. This is where I think we need to be focusing on community engagement and asking for earlier participation from the people who are going to be subjected to the decisions made by these models. I think a lot of times, and maybe some would consider this conversation an ivory tower conversation where we're discussing the details of something that a lot of people still don't understand but are still subject to. This could qualify. I think we need to engage people who are citizen scientists, who are concerned community members, that and ask them, like, how do you think something like this could impact your community? And I assure you, we will have ideas that we had not even thought of. When we think about the fact that tech is not diverse at all, that is what has led the lack of diversity, I think, is what has led a lot of these problems to go on for so long. And we can think of diversity being racial, gender, etc., but it also can be just one's like situates how someone is situated in society, like their profession, and how much they know about AI to begin with. And I don't think you have to be an expert on it to have an opinion on how it could impact your life. I'm always pleasantly energized by patients that I interact with, who I have these conversations with, really in sort of what I would consider a harm reduction stance, telling them about how these models may be rolled out soon and used in their healthcare, and hearing their perspectives. And they don't have to be experts to have pretty strong opinions and good ideas on how things could be changed. So in summary, I think we should be asking people outside of the technical world, outside of the expert opinion, about how they feel about what risk should be acceptable. I think, of course, this will likely be set by regulatory bodies, but like the FDA, for example. But the FDA has failed large groups of people often people from disinvested communities before. So I don't feel comfortable putting all of this in their hands, though I do think we need some sort of standardized way of determining what the threshold should be. I think that should be inclusive of people who are going to be subject to these outcomes.
Yeah. I really like this idea of community engagement. And it's something that's troubled me for a while because the whole conversation around artificial intelligence and large language models has been intentionally devoid of any community participation. And in fact, as we go further and further along, the conversation is like really in a very deliberate way, not trying to engage the public or educate the public upon what this technology means or how it works. And the example I always give is that, if you're driving into San Francisco from the East Bay, or you're driving back from San Francisco Airport to San Francisco, the city itself, all you see are all these billboards from all these AI companies. And these billboards are entirely incoherent to anyone who was not specifically in the field of artificial intelligence.
A small stretch of highway dripping with money.
Yes, exactly. And to me, like, I've always thought of billboards as being a public space. It's an advertisement to kind of bring the public in, whether it's a billboard for Coca-Cola or a billboard for Gap jeans, right? Billboards have always been this common place where a corporation is trying to sell something to the public. And here you have this stretch of highway where, again, you have these numerous billboards, row after row after row, that are, again, like, some of them have code on them that, again, only coders will understand. Others are engaged in these kind of very technical AI conversations that, again, the public can't understand. And so there's this kind of, it's like throwing it in our face that this technology is above what the public is able to comprehend. And that's not a very good space to be in, particularly when the conversation that's happening in parallel with this is that AI is going to transform every aspect of our lives. And so the public is put in this position where they know that this technology exists, but no one's ever talking to them about what the public wants from this technology. So, in public health, we have this approach called CBPR. So this is community-based participatory research. And the whole idea is that, if you're going to engage in public health research or knowledge building, that knowledge has to first come from the community itself, and that the community should be active participants in shaping the research agenda. And, it would be really wonderful for something like that to emerge in artificial intelligence research or the development of large language models. That is to say that this work probably should not only be directed by these multi-billion dollar corporations and their profit-seeking interests, but should also be oriented by what are the people's needs and what are their thoughts and perspectives.
That's on purpose.
Yeah.
Oh, sorry.
No, go on, Roxana.
Yeah, that is on purpose. And I have to give a shout out to Jenna. I have wanted to read this book, but I've just been busy. But she pushed me to start Karen Howe's Empires of AI.
Mm-hmm.
And in that book, literally, the men have dinners and meetings where they decide that they are the only ones who are capable of, quote, building this super intelligence, monitoring the super intelligence, profiting off of the super intelligence. And I mean, okay, the last part they don't say, but like they frame it as they're doing it for the good of society, right? But like, what society? For whom? Whose perspective is missing from that? And the problem here, honestly, is they do not want the perspective of everybody else. I think those of us who do research in the space of ethical and responsible AI want the community brought in, and there are efforts that, with community engagement, AI, and patient engagement, and all that stuff. But the problem is the money and the power right now are actually in the hands of those who do not care and, paternalistically believe that they are the only ones that can understand, build, and handle this technology. And it is creating, in my view, quite a dangerous dystopian world that we have to push back against.
Right.
I was going to say that I think that the area of employment is a little bit different from public health, and that in employment, employers expect to set up their own processes. They expect to have control over their own processes. So I think the role of the community might be a little bit different. But I really want to stress, based on 15 years of this kind of work, what Tofunmi said and how important it is auditing. What we know is that AI is pattern recognition and bias is pattern recognition. There is going to be bias in AI. You cannot build AI without reflecting these biases, but you can go back and through careful auditing and fine-tuning, eliminate some of these really dramatic differences in the treatment of groups in the talent management process, for all the way from hiring to who gets good assignments to performance evaluations. In all of that, AI is here. AI is happening. And it's currently that the knowledge base does exist to go back and teach people how to do the auditing, how to upgrade these systems so they don't reflect kind of the worst of who we are. There's another element that comes in from employment, which is that AI now is very widely being very, very widely used in the application process. And the results are that people can apply a lot more places. And the result is that employers feel completely overwhelmed by the number of applications. And so the word on the street is it's now become, again, much more important to know someone on the inside in order actually to get into the realistic applicant pool, to get an interview, for example. And, in-group favoritism is one of the strongest and most consistent findings in social psychology. And you do not, so if what you're going to have is duplicating the demography of your organization if you don't use AI in a thoughtful fashion. But in employment, AI is already being used, and I think that I can't stress enough the importance of auditing and going back and fine-tuning, not being satisfied with the first cut, because we know that the first cut is going to be really deeply flawed.
Jenna, you wanted to jump in?
Yeah, I just wanted to reflect a second and maybe say the quiet part out loud. We were talking a lot about how we can monitor and how we can adjust algorithms and I guess the natural next question is why isn't that happening? And the sort of nihilistic, like jaded side of me, or really just the student of history in me says that AI is just really another tool to exclude people. And we really don't necessarily want to make people's health outcomes better. We've seen for decades why the intricacies of why health outcomes are the way they are. And the answer is we cut 16 million people off Medicaid. We see why how health and employment are connected, how health and justice are connected, and we don't do anything to mitigate the negative sort of cycles that people get in. So these companies are not unaware of the bias that exists. They're just so much more interested in money and the race to the bottom than they are in fixing any of these things. And I think to your point about the billboards, I think you're right that they're not talking to the average person, but I think they are trying to get people hooked on an idea before they really know what that idea is. And regulatory rules allow pharmaceutical companies to advertise their medicines without saying side effects, as long as they don't say what the medicine does. So I'll never forget when I was younger seeing a commercial of these people like frolicking around in a meadow saying, ask your doctor what like XYZ medicine is about. And I remember thinking like, what does that medicine even do? And the whole point is to not say what it does, because then you can get people hooked on a brand and an idea before they know all the bad things about it. So I think that these things are intentional. And we need a different strategy. And I think the strategy is educating the community on these topics, because if we can create a groundswell of people who are demanding different, and we are speaking in the language of capitalism of these companies, and we have people who've developed a consciousness where they are not just buying or using any old tool, and they know the intricacies and the problems, and they are voting with their wallet and doing something else. That's really the only thing that's going to push these companies to do different.
Right, right. And I think this is such an important point. And I think, it's something, one thing we also have to keep in mind is that at the most, at the furthest end of this conversation, it's not a coincidence that the biggest proponents of AI are also the very people who are against democracy or don't think democracy is an effective or efficient way to govern society. And so we have to think seriously about why those two ideas come together at that point, because as all of you are saying, it's not an accident that we are intentionally not being spoken to about the promise and power of this technology. So we're at the end of this panel, but I want to give each panelist a minute or so to kind of offer some concluding thoughts. If there are moments of optimism that you have in your mind, or opportunities for us to kind of productively move forward, or just to wrap up in any way you find useful. So we'll start with Tofunmi.
Yeah, I think I'm just gonna summarize many of the things everyone has said. Yeah, I think the point of community engagement is like Jenna mentioned is extremely important, especially for healthcare systems that serve all these big communities, right? When all these AI vendors come in, kind of like just involving the communities, setting up all these governance and recurrent auditing of those models. I think that's like that can have one of the biggest impact on health outcomes, because the vendors can promise anything, but how does this perform in your patient population, and what do the outcomes look like 3 months, 6 months from now?
Mhm. And Joan?
I think my message to the companies is that if you want your HR processes to provide a consistent employee experience, that's not something that's going to happen in AI by default. AI is not going to be perfect. No tool ever made by people was perfect, but it's going to happen. It's already happening in all of these HR processes. And the next step is to audit and to get new generations of AI that provide just very simply a consistent experience for different groups.
Great. Thank you. Jenna?
I just want to highlight my moment of optimism, which is that I think collectively as people we're very powerful. And I know that maybe sounds like kumbaya, flowers, and like rainbows and stuff, but I really think it's true. And I think there's more and more efforts to try to make us forget that. And I think it's important for people in academics, people in all sorts of all disciplines, people who are outside of the academic sort of world, to remember that, and to remember the reason why these things aren't clear, why people aren't speaking to us, is because they're worried about what will happen once we learn, and once we develop this collective consciousness about what's going on. So just pushing everyone in the audience to do this themselves and to educate community members as much as you can, because I think that's really the thing that will turn the tide.
Great. Thank you. And Roxana?
Thank you so much for having me here today. I've really learned from everyone's insights as well. I think I will again kind of summarize something that was mentioned in Karen Howe's book, which I think also builds on what Jenna just said, which is it doesn't have to be like this, right? Like this is how things are right now, but there is opportunities for course correction. I have the privilege and opportunity to train students in the space of AI in healthcare, and they are thoughtful. They come from diverse backgrounds and diverse experiences, and they are cognizant of these problems. They want to learn about these problems. They want to care about these problems, because the reality is that in order to address them, we can't be talking about them after the AI is implemented. We need to be thinking about it every step of the paradigm, and we need to sort of build kind of a new paradigm, because currently the way things are going, it's not working, but it also doesn't have to be like this.
Great. Well, thank you all for this incredible conversation. This has, I think, been really fruitful and productive, and I want to thank each of the panelists, Tofunmi Omiye, Joan Williams, Jenna Lester, and Roxana Daneshjou. And thank you to the Berkeley Technology Law Journal for convening this symposium. We hope you all enjoy the rest of the symposium, and take care.